We welcome Dr. Todd Duellman. He's been helping patients get their hula back since 2006.
Yes.
All right. He helps patients with shoulder, knee, and hip pain, as well as those who suffer from sports and work-related injuries. He performs a less invasive hip replacement procedure that is extremely successful. Dr. Duellman is a graduate of GET High School, so he knows the area very well. He lives in Wisconsin Rapids with his family. He enjoys playing basketball, hockey, and football, as well as fishing, traveling, and spending time with his family. And we are very blessed to have him working with us and our patients. So I will, on that note,
Thank
I'll
you very
give it
much.
to you.
Thank you. First off, thanks for having me, and make sure you take the tours of the hospital. I'm sure most of you all have been in the hospital, but the rehab department and the surgery department are fantastic. I've operated at many different hospitals and been in a bunch of different spots, and absolutely fantastic services. So, first and foremost, I do all kinds of different surgeries. Orthopedics, I do anything as long as it's not the back. Hands, knees, feet, hips, shoulders, sports injuries, work injuries, and those types of things. But obviously, that's a huge talk to talk about. So we're going to talk about something that I truly, truly love. It's kind of like everything in life. Once you start to learn a little bit about something, you learn more and more about it. Start to become. See, they're excited about it already. They haven't even started. They haven't even showed a picture, and they love it already. So you learn more about it, you start to do it more. And this is we're going to talk about hip replacements specifically tonight. But like I said, we run the full gamut for what I do. I'm a general orthopedic surgeon. I was born and raised in Trumbull County, as Amy said, so I'm a native of Galesville. Mom and Dad are still there. I went to Marquette, Milwaukee, for my undergraduate degree, which was in Spanish, which doesn't do me a lot of good. Dad taught shop, so you can imagine what he said when he walked across the stage with her Spanish degree. What are you going to do with your life? So I went back to school, got a master's in physical therapy, worked as a therapist for just a year, and then went back to school again, and to Medical College of Wisconsin, I got my medical degree. From there, I went down to Illinois with the Flatlanders, did my residency training in orthopedic surgery, and I joined Wisconsin Orthopedics in Rapids in 2006, and this is completing my second year here at Black River. We did another talk similar to this 2 years ago here in Black River. A little less attended, but we didn't serve food, so that was probably so Amy's learned. So I became interested in what's called the anterior hip 6 years ago. The traditional hip, we'll go through what that is and kind of what the anterior hip is, and we'll talk about that. I performed my first, when you see ASI, ASI just means anterior hip. Basically, all we're talking about is an incision in the front. And we'll get to why that's important, but I performed my first one in Wisconsin more than 5 years ago, and I haven't went kind of to the back since that time. I go around the country speaking to other surgeons as how to do the surgery. We actually have people come here to Black River Falls to observe the surgery, other surgeons, to learn how to do it. We have one coming next week to Rapids to learn how to do it, and so I'm a facilitator in that regard for other surgeons, which turns out to be great because I learn from them, they learn from me, and it ends up being better results for you all. So tonight's plan, just briefly, pretty basic. Basic anatomy, what is arthritis, what can you do with arthritis that's not an operation, what is a traditional hip replacement, what's the anterior hip replacement, and then a little video and then questions at the end. So this is just a basic hip. It's a ball and socket. You've got a socket and you've got a ball. So when you walk, basically the ball just moves in the socket. Pretty basic. On top of the ball is a smooth surface. Think of it, the laminate on your floor. It's a nice smooth surface and it rubs in there. But if it's smooth, it rubs back and forth and it doesn't hurt. Arthritis is basically the laminate floor now is peeling up at different spots. And so now when you walk, you get bone rubbing on bone, causes pain, inflammation, and it hurts. Interestingly, there's more than 100 different types of arthritis. Obviously, we hear of two mainly, osteoarthritis and rheumatoid arthritis. The end result of all of them is joint destruction and pain. It affects a lot of people every year. So what are the symptoms of hip arthritis? Amazingly, if you ask somebody where their hip is, everybody will point to a different location. They'll point to the side, they'll point to the butt, they'll point to the groin, but truly, hip arthritis pain typically hurts in the groin. And you'll hear people complain that it's difficult to lift their leg into a car. It hurts lifting your leg into the bed. They can't tie their shoes because they can't turn their hip to bend over and do that anymore. They'll be stiff, immobile. Most of them will limp. You've all seen the person who walks and kind of does the shakes to one side. Often that's a sign of a bad hip. But those are typically what people will come in and complain about. And as you can see in the picture, it's red, it's inflamed, and it hurts. So how do you get a proper diagnosis? Typically just an x-ray. You don't need an MRI, you don't need a CT scan, you don't need any high-end imaging, just a regular good old-fashioned x-ray will show you. But you also go on the patient's symptoms, what their overall health is, their activity level. And this x-ray shows two bad hips, but once again you have the ball, you have the socket, and there should be a space between the ball and the socket. And we'll show a picture of that. So here's a normal hip. You've got a nice ball and a socket, and there's a space between them. But if you look at this picture, you've got a ball, and there is no space in that socket. And so that hurts. That person clearly is in pain every time they move. They've got rough rubbing on rough. So what you see is you see the joint space narrowing, and you see these bone spurs. Now, a lot of people will come in and say, well, doc told me I had bone spurs. Let's just get rid of them. Well, you can imagine that if you go and take this bone spur off and that bone spur, what are you left with? You still got bone rubbing on bone, so you didn't solve the problem. The problem truly is bone rubbing on bone. The x-rays just show spurs, that's just an end result. So what can be done? This is typically done before you see me, or these are things you typically do by yourself. You modify your activities. If it hurts when you walk a mile, you don't walk a mile. Some people will use a cane, crutch. People will try hot packs, cold packs, medications, whether they be ibuprofen, Aleve, Motrin, Tylenol, all those things, which is good. Topical creams. Injections for the hip don't work real well. They can buy you some time. They might work for a few months. Some people are lucky and they'll get a year out of it, but not very predictable. And those are, we're talking about cortisone injections or steroid shots. And last but not least, what we're talking about today is joint replacement. So when do you consider a joint replacement? One of the people will come in often and say, well, do I need my hip replaced? I will never ever tell anybody that they need a joint replaced. You all will tell me. You're really sick of the pain. Those conservative things won't be working. You'll have an x-ray that is concordant or looks like it's an arthritic hip. And when you're sick of the pain and can't do the things that you want to do in life, whether that be take the dog out, go for a walk with friends, family, shopping, hunting, whatever it is, when those things you're not able to do anymore, then that's when you should consider it. But not before, because there's risks involved, and we'll go with that. So the main benefit should be 1, 2, and 3. It gets rid of hip pain. That's the entire goal for surgery. It's pain relief, pain relief, pain relief. And if you're not having pain and you got a bad x-ray, don't have your hip replaced. The only reason you should do it is for pain relief. And when you get rid of the pain, you'll be able to move better, and it will improve your quality of life. So it all kind of follows that. If you can get rid of the pain, things will go well. So this is a picture of a hip replacement. Not real bone, just a model. But what you see is the socket. You see a metal socket. You see what was the stem, but the ball now is gone. You actually take the ball out of your hip and throw it away. And you put in a substitute with metal and plastic. So what happens is you put a stem down inside the thigh bone and a ball or a new socket inside the pelvis bone. And your body will grow into those. So this is just another picture. Once again, though, you can see the socket, you can see the stem down inside the thigh bone. So we have models up here that actually are real models, and this is all the bigger it is. It's pretty amazing. Whether you're 100 pounds or 400 pounds, this is what holds you up then for the rest of your life. And it's got a rough surface. This picture doesn't show, but it's got a rough surface on there, and your body grows into that, which is pretty phenomenal. But there's different sockets and different balls, different sizes for everyone. Just a picture of an implant. The ball can be many different things. It can be ceramic or it can be metal. It can be different sizes. This pink one here is a ceramic one. Typically it's more expensive, and it's saved for somebody who's younger because it's expensive and it can break. So we don't usually use that too often. So we use traditional components. We use metal and plastic. It's proven and it works. For me, inside the operating room, it gives me much different latitude. I can do a lot of things with it, with metal and plastic as far as sizing and stuff. So it offers you the best option. And typically, our goal is for it to last 20 years. It's kind of, people always say, well, how long is it going to last? 20 years. What's really neat is, you see this piece of plastic in the middle? Just like the brake pad on your car, if you wear the plastic out, or the brake pad, that just pops off and you can put a new piece of plastic in. So you don't have to change everything. And to use the car analogy, you wouldn't have to turn the rotors if you catch it early. Hip resurfacing. So you've probably heard of hip resurfacing or metal on metal. If you stay up late at night, it's what the attorneys often talk about right now. No offense to the attorneys in the room. But what it is if you rub two pieces of metal together, the idea was that plastic that we saw here, this plastic's going to wear out. So the orthopedic surgeon in us said, well, if I rub metal on metal together, it won't wear out. But what we didn't realize is that when you rub two pieces of metal together, ions are released. And those ions can cause trouble inside the body. And so this isn't done very often anymore. You can see what they did is they saved the neck, they didn't cut as much bone away, and it basically acted like a cap. About 6-7 years ago, almost 30% of the hip replacements in our country wore this. Now it's less than about 4%. So if you came to me and said you wanted this done, I'd help you find a surgeon that would do it. I wouldn't do this to anyone here. So back to this picture. Here, this white plastic typically wore out relatively quick. So we went to metal on metal, which clearly didn't work. So then we went to metal on a pinker piece of plastic that has vitamin E in it. What that means for you all, or for anybody undergoing a hip replacement surgery, is that it will last longer, and you don't have the metal rubbing on metal. So if you have your hip done in Black River Falls tomorrow, you'll get the highly cross-linked or the fancy plastic piece of poly, which is basically, instead of wearing out at that 20-year mark, hopefully lasts much longer. And that's the goal of that. So basically, it's improved properties versus the traditional plastic. So it doesn't wear out as much, and you don't have the metal rubbing on metal. So a hip replacement, no matter what, is to take care of the pain. Whether you do a traditional incision or an anterior incision, the components are essentially the same. Your options are the same. I can ask 4 different people how to get to Walmart, and you might get 4 different answers. But the end result is you get to Walmart. So as far as a hip replacement goes, you can make an incision on the side of the hip, you can make it on the buttock, or you can make it in the front. But what's the difference in that? Why? Well, each one has a different pattern to get there, or a different path. Whether you go down this road and take it right, everyone just have different paths. So the anterior incision goes right in the front, and that's what we're talking about today, and that's what I do. The amazing part of that is you don't have to cut any muscles. And it sounds crazy when you think about it, but you don't have to cut a muscle to get in. It's pretty amazing. With that, there's less tissue damage. If you don't cut muscles, obviously you're not hurting as much of the body. If anybody's ever skinned a deer or cleaned a deer or cleaned game, you can put your finger between the muscles and wiggle it back and forth, and they just kind of separate. And that's true in us as well. So if you make the incision in the front, the hip is very close to the front. And you can just put your finger in there and separate the tissue and get down to the hip joint very easily. But from a posterior approach, or from a side approach, you all got a lot of meat right here. And so to get in, you've got to cut a lot of that muscle down. So this is the incision for an anterior hip. Hopefully the video works here. It's cartoon. It's not meant to gross anyone out while you're eating. Probably poor planning. But this is just the front of the hip. And what you're going to see is the incision is not near that big. So they're just showing the different layers. And here's the muscles. You literally put your finger between the 2 muscles and they'll separate. And that's the ball and the socket. So in the surgery, you'll cut off the ball and you'll take the entire ball out so you can see down into the socket. So now you've got to make a place for the socket. The only way to do that is to use what's called a coring reamer to give it space. And after that coring reamer is done, you put in a socket or a shell. That's this, and it's made out of titanium. Then you have to access the thigh bone to put that stem down. And that's all you're doing. You're clearing out the marrow and putting the stem down inside the thigh bone. And then you trial different sizes to make sure your leg lengths are perfect. Now this picture has exactly what I told you I wouldn't do. It has metal on metal, but I didn't make the cartoon. So then everything just kind of falls back in place because you didn't cut the muscle. Now what advantages does that have? Well, by going through the front, we can do a couple different things. We'll use bone conserving implants. You see a longer stem and a shorter stem. We can use a shorter stem, and if we use a shorter stem, we don't dissect as much, we don't cause as much damage, we don't cause as much bleeding, and your recovery is quicker. What's amazing is the anterior approach was actually, the way to get into the hip was written by a guy from Milwaukee almost 100 years ago. But it's now finally coming to light as far as a way to do hip replacement surgery. The approach is not new. We use it with children. It's a traditional approach used for children. Anytime a child has a hip problem, you'd go through the front so you didn't have to cut their muscles down. But what happened about 7, 8 years ago, an engineer got a hold of things, at least in our country, and redesigned the tools so we could put in the same implants through the front. They've been doing it in France for a long time, for more than 20 years actually. So the advantages over a traditional hip is you're sparing tissue. You're not cutting any muscles. When you do a traditional hip, you don't have the ability to use an x-ray machine as you do it. But with this, you're lying on your back, and we can use an x-ray machine so we know exactly where the components are before you put them in. So you get feedback from your eyes looking at it, and you have a computer or an x-ray machine helping you, so you can put them in the right position. If they're in the right position, you have a less chance of dislocation. Dislocation meaning that the ball can pop out of the socket, which is a scary thing to say. Through a traditional approach from the backside, that's anywhere from 2 to 6%, depends on what you read. From a front approach, it's 0.6% is the dislocation rate. So it's taken it down almost a factor of 10. And because the better component position and because you didn't cut the muscles. So what does it mean for the patient? Less pain means a quicker recovery. So you're back doing the things you want to do sooner. You're able to walk right away. The day of your operation, you're up walking. Most persons go home the next day. If a traditional hip replacement, you often had to sleep with a pillow between your knees for 6 weeks. With this approach, you don't have to do that. Minimal need for post-op therapy. We don't send you to therapy for 6 weeks or anything like that. You're just seen while you're here typically. When you have a traditional incision, they tell you 3 things you can't do for the rest of your life. They tell you not to cross your legs. They tell you never to bend 90 degrees at the waist or rotate your hip out because of the risk of dislocation, because you cut the muscles in the back. Well, if you do a post or an anterior approach, you don't have those risks. So there are no restrictions to movement, less dislocation length or less dislocation risk, and then leg lengths. People make a big deal of leg lengths in hip surgery, and because it's the most litigious reason you're going to get sued is if the leg lengths are off. But realistically, from a side approach, it's very difficult to determine leg lengths. While you're on your back, it's much easier because you're lying flat, and Dawn is measuring your leg lengths as we do the surgery, and we can adjust your leg lengths throughout the entire surgery. What it means for me, if there's no muscles cut, I've got less stuff to repair at the end. I've got excellent visibility during surgery. Normal hip mechanics. If you're not cutting the muscles, things are going to work normally once your hip's put back together. Leg lengths is easier to determine. Reduced dislocation risk, meaning less headache. Component position. This is the component going in. Before I hit it, you take a picture and make sure it's where you want, and that's the socket inside the pelvis. So you have direct feedback, whereas from a posterior approach, you don't get that. Obesity, people will tell you they do an anterior approach, but then you have to qualify it. Obesity is not much of an issue at all. None of us really have a lot of fat right here on our front of our thighs. So that's really a non-issue. And for me, all of these things translate to happier patients, which makes clinical a lot easier. So what does it mean for here at Black River? First off, the patient is healthy. You'll never do a surgery on somebody unless the patient is healthy. So we treat you as such. You dress in your own clothes. If you put on a gown, we all become dependent, and we ask, we want the nurse or we want the assistant to help us. But if you're in your own clothes, you feel like getting up. That way your butt's not hanging out the back. So we treat you as healthy. We get you up right away. We mobilize you. You're out of bed for all meals right away. The day of your surgery, you're up walking. There are no hip precautions. We don't use a lot of narcotics, or we try not to use a lot of narcotics after surgery, just because if you're using narcotics, often you don't feel well. You might be nauseated and might vomit, and then you wouldn't go to therapy, and then you wouldn't go home. So the idea is if we can minimize that, minimize your pain, we can get you up, get you moving quicker, and get you home. And that's where you need to be. So complications, like anything, when you hear the drug advertisement on TV, they have that long list of complications that happens at the end. But it's not without its problems. It's not without the infection. It's not without blood clots. Implant breakage is very rare. Malalignment, once again, you have a direct feedback. So all of these are minimalized. These same risks are with a traditional posterior approach as well. But we can minimize some of them through an anterior approach. No implant will last forever. Whether it's ceramic, whether it's metal on metal, we can all wear it out. And last complication is your heart and lungs. We're never sure what they'll do. We have you see your real medical doctor before we would do any other type of surgery. So to minimize complications, typically we ask people to get dental work done before surgery. Prepare your home. And this one's a big one, but you need to see your primary care physician because they determine if you're healthy enough to undergo the operation. I don't. So they're the ones who are going to see you to clear your heart, lungs, and to see whether or not you're worthy if you can undergo the surgery. So you return to golfing, swimming, usually about 1 to 2 months. Many people, that's pretty conservative. We basically just ask that you don't take up running, jumping, and jogging. And usually by the time that somebody shows up needing a hip replacement, those 3 things are by the wayside already. So where do you go from here? Basically, today's just an informational session, but if you would want to be contacted or if you would have any interest in an appointment, you always can go through your primary care physician or you can come directly through us. The number's here. There's cards up front here as far as getting a hold of us. You call our Rapids location, but we see all the patients at our Chrome clinic. They're nice enough to lend us space. And so we see the patients there, but your surgery then is done here at the hospital. And if you call that number, Gina is the girl who takes all the patient information, contact, and get your insurance approved and all those things. But we handle it from there. So 1 second for your questions. I get to ask my questions first. But first, in the back, 2 people. Number 1 is Nick in the gray shirt. He's the gentleman who brought the implants for you to trial. Don't take any of those home for souvenirs, otherwise he doesn't have a job. And next to Nick is Dawn. Dawn is my best friend, and when you see her in clinic, you get to have her be your friend too, but you don't get to take her. Because you'll have her number, you'll have a way to contact Dawn or I, no matter what happens with thick or thin on your surgery. So those are those 2 people. They'll be around to ask questions. So, all right, so I get to ask a couple questions. It's not trivia, but it's for giveaway. All right. Where's the Garden of Eden in Wisconsin?
Galesville.
Oh, there's, you got Galesville already. Rocky Road. Just hold that, that's good for later. Alright? Alright, so, alright. Where is a traditional hip incision made? That's a hard one.
Posterior.
Posterior, there you go. Alright. We got one. Alright, good. And here's the harder one. When did I start working in Black River?
2 years ago.
Boy, it can't be at once. What's that? 2011. You got it. See, he's the only one who raised his hand. All right. Let's see. Who introduced me?
Amy.
Don.
How do you know Amy? All right. And
No.
Oh.
if we replace your hip, what day do you get out of bed to go walk?
Same
There
day.
First
you
day.
go. That's what I like to hear. And save the teas. They're for good stuff later. Let's see what else. I don't know. What else? Amy, what else you got for questions?
You were asking something about Blair before.
Oh, what's it say on the sign when you drive into Blair? There it is. Yeah, she got her lefts and everything. She's winning everything. All right. All right. That's about all I got. All right. So, Amy, you want to take over as far as?
Absolutely.
Oh, questions. I'm sorry.
Yeah,
Yes.
question.
Sorry, you don't get it yet. Sorry.
Okay.
I'm sorry.
There's a question behind me first.
Yes.
Okay, you say these wear out. What happens when they wear out?
Great question. So, well, the question was, what happens if the hip wears out? What do you do? Let me get to a picture that would make sense. So everything will wear out in time. It's just mechanical. Oh, we're getting to one.
Here's the actual.
There you go. All right, fantastic. All right. So, where's the arch? All right. So here's the bowl and socket. Inside the socket is a piece of plastic. If you rub this together long enough, that plastic will wear out, no question. So what it requires a surgery to fix. That piece of plastic, there's a little tool that goes behind it that pops it out. And so what you do is literally, you open up the hip, you turn the hip out, you take out the piece of plastic, put a new piece of plastic in, and you're done.
Is it basically the same surgery again?
100 times easier because you don't cut any bone.
That's what I was wondering.
So you're not cutting any bone.
It's quicker.
It's quicker, your recovery's faster.
You gotta cut the same place though. You go in.
Yeah, you cut the exact same spot. So you're just putting a scar over the top of the other scar, and you replace the plastic piece back out.
What is the life expectancy? Not your life, but I mean the joints
Our goal
expectancy then.
is 20 years.
Another 20 years
Yep.
On the replacement part?
Yep. Yep.
Okay.
You know, what's interesting is it typically lasts longer the second time for the fact that we're older and we don't put as many cycles on it. If you put a hip replacement in a 20-year-old, they're going to move their leg a lot more than somebody who's 70 years old. And so their hip may not last 20 years. If they're going to put more cycles on it, they'll wear out the plastic sooner. But as we age, we don't put as many cycles on it, and then it lasts longer. Yeah.
Well, I meant, my question, how does a person know that it's worn?
Oh, I'm sorry. Yeah.
What?
Great question. So how do you know the
You're not gonna have a
plastic piece is wearing out?
joint problem.
You x-ray it about every 5 years. Let me get to the picture here. So every 5 years, if you x-ray it, what you'll see is the plastic, or the ball, is starting to migrate north, meaning that the plastic is worn higher up. So if you rub back and forth long enough, you're going to wear the plastic out on the top, not down here. So what happens is you get an x-ray and the ball looks like it's farther north, and then you follow that. And you know how thick the plastic is at the time of your surgery. And so when it gets to be, 5, 10, 15 years, as you x-ray it each time, you'll see that ball changing in position. And when it changes in position such that you think it's going to become metal on metal because you've measured that distance, then it's time to change it. So x-rays, routine follow-up is the standard answer every 5 years. So if you had your hip done today or 6 months ago, I would say, great, see me in 5 years. And then at 5-year intervals, you would check it. It doesn't fail catastrophically. It's not, the laminate floor doesn't wear through right away. It takes multiple millions of cycles to get it to wear through. So you have time to watch it. Yeah.
Typical surgery time for the initial
operation versus the replacement count?
The initial operation, people always, how long does it take? Well, it takes, when you get into the operating room, it takes about 20 minutes to get it set up, 20 to 30 minutes to get set up. Surgery can take anywhere from 1 hour to 2 hours. Is a pretty standard OR time. Incision length, that we did one this morning, it took a little bit longer, it took 2 hours. Standardly about an hour and 10, hour and 15 minutes, but we tried to make a pretty incision for him, and it was about that big to get the hip in. So we made a really small incision in the front. So that took a little extra time, but usually 1 to 2 hours. And we do it with you numb from the waist down and you're sleeping. The other side of the surgery is if you're just replacing the plastic, 35 to 40 minutes. Yeah.
If you have a lot of these symptoms that are mentioned up there, do you see your primary care doctor first, or do you see me first?
Just because I'm not here every week, I'm here every other week.
Right.
Often we have you see your primary doctor first.
And then he can.
He will refer you on if those symptoms went alongside of it.
That's a good idea.
The primary care doctors are, at least in my eyes, and somebody can correct me if there's some here, are kind of the gatekeeper still,
right.
To evaluate, decide, and those types of things. Yeah.
Can knee pain be related to a bad hip?
Absolutely. The question is, can knee pain be related to a bad hip? You'll have many people come in at different times who will come in with a bad knee. And they'll have that knee x-rayed, they'll have it MRI'd, they'll have it injected, they'll have all kinds of things done to it, but nothing's changed the knee pain. And then you'll get an x-ray of a hip and it will look like one of those x-rays here. And amazingly, it's tough to convince that patient that, listen, the problem's your hip. And when you replace the hip, the knee pain goes away. And that's just the way we're wired. The nerves cross the hip joint and go to the knee. And so it can be